Morning, everybody. Welcome from Madras Medical Mission. We have a very interesting case here today. This is with me, Dr. Nandakumar, who's going to work with me with an interesting case. Before we go into the case, I want to introduce my colleague, Dr. Ashish, who will join me here. And we have nursing staff, Prabhu, the technician, and all the others here to help us with this case. So can we go to the first slide, and Dr. Nandakumar will explain to you what is the history of this patient. So Dr. Nandakumar, please go ahead and give us the case history. So this is, as Nandakumar comes towards the computer, this is a 78-year-old gentleman, and Nandakumar will tell you the case, please. Yeah, go ahead.
So here is a 78 years old gentleman uh, presented to us actually in the OPD with the syncope. During the syncope, we found out he was in paroxysmal CHB, and the evaluation showed there is a severe calcific aortic stenosis also. In the index admission, he underwent dual chamber pacemaker for the syncopal episode and paroxysmal CHB and planned for elective transcatheter aortic valve implantation later. So while evaluating the aortic stenosis, the peak gradient across the aortic valve was 88 millimeters of mercury and the mean gradient was 53 millimeters of mercury. He has comorbid conditions like diabetes mellitus and systemic hypertension. His LV function was normal. LV ejection fraction was 62%. Coronaries were essentially normal. And STS score was 1.5%, so he fits into low risk TAVI category. Euro 2 score was 1.1%. And coming to the CT assessment, if you see the annulus measurement shows the area of 363.5 square millimeter, which corresponds to area derived diameter of 21.5 millimeter, and perimeter of 68.8 millimeter, which comes to 21.9 millimeter, is the perimeter derived diameter. And we can clearly see here there is a calcium spicule at the NCC side, which is actually even extending into the LVOT into the conduction system, which we are going to see in a double oblique view clearly. So this may be the reason for his CHV. This LVOT calcium on the NCC side is protruding into the conduction system. And this is the sinus of Valsalva, and this clearly it's a tricuspid valve. And coming to the coronary measurements, see, if you see actually the basal plane, I went a little 1 or 2 millimeter down to the LVOT. So the left coronary height measures 15.7 millimeter, maybe one another measurements, it can come 2 millimeter above. So left coronary height somewhere around maybe some 12 to 15 millimeter. And the sinus of Valsalva height on the left coronary side is pretty huge, 20 millimeter. Right side, the right coronary height is 11.6 millimeter and sinus of Valsalva is 18.6 millimeter. And this is a sinotubular junction is very roomy, 29 and 30 millimeter. Ascending aorta is measures 31 to 32 millimeter. And sinus of Valsalva width, again, everywhere it is more than 29 millimeter, especially on the left side it is 31 millimeter, and the right coronary side it is 30 millimeter. The aortic angle is 37 degrees, and there is enough amount of calcium to hold the valve in place. So then move to the femoral. If you see, there is no big tortuosity, and measurements, the right side femoral 7.4, the minimum diameter is at the external iliac artery 6.6, which is more than enough for our valve of somewhere we are going to discuss about, is it 21.5 or 23. And left side is also, it's good size, even in fact better size, but we have decided to go on the right side for easy of ergonomics point of view. So with that,
So thank you, Nanda. And as he washes into the case, we'll show what we did right now. So the plan is to go ahead with transcatheter aortic valve replacement, which a middle valve, And the plan is to take accesses on both sides. So both side accesses have been taken under ultrasound guidance, and we have put two 6-French catheters in the left groin and the right groin. Now, if you look at the Merrill valve, can we go to the previous slide? The Merrill valve is a balloon expandable valve made in India. It's approved in India in 2018 and CE marked in April 2019. On looking at the valve, we think it's about 22 millimeters is what we need to do. So we're going to take a 23 millimeter valve, which is about 14.6% oversized, and go 1 ml less, which is about 4%, which will be about 22 millimeters. Now, if you look at the metal valve, it has a closed cell and an open cell design. The covered area uh, is about 16 millimeters for this valve, about 18 millimeters for this valve. And you can see that the 9 millimeters will be closed and 9 will be open. And the 9 millimeter part, we will implant 3 millimeter deep. So we'll have about 6 millimeter of the covered part closed on the top, and then another 9, which is there with an open cell. You can also show you what the delivery system is like. It's a very sleek system. It's got the Navigator hard delivery system, which has a 14 French Python sheath. The name comes from the Python, comes from its ability to dilate up to 18 French. It's also got a steerable system, which we'll show you as we implant the valve. And it has also got an ability to steer the catheter without much difficulty across the ascending aorta. There are three important parts of the metal system, which is very important. One, we have half sizes, which is not available with the Edwards system. So we can really balloon size it to the adequate amount. The number two, we do not need to load, after loading the valve, we don't need to do anything in the aorta. It's all preloaded systems. We also have a commissural alignment software, which we can use for aligning it. My colleague Nandakumar will explain to you when you implant the valve, how we do that. And finally, I think it's a very steerable system, and in the most difficult of anatomies, we could help to steer this valve across the valve. So our plan now is that we have taken both the we've taken both the accesses and ultrasound guidance. If you can see on the leg, there's a left and right. And now we will upgrade the right axis, which is what we are going to use for our delivery of the system and crossing the valve, and put a pigtail up the left. In the meantime, we will give some heparin to the patient. Uh, can we give heparin? What's his weight? 57. So we can give 6,000 units of heparin. The patient is preloaded with dual antiplatelet treatment, aspirin and Plavix. Can I have a pigtail catheter, please? 6 French for the left side. And our process now will be to keep the pigtail, do a shoot in the from the left sided femoral artery. And then we will look at we'll predilate and put yeah.
The proglides.
Okay. So before that, we're going to put the proglides in. Get the proglides, please. Wire.
Wire. Give me the Teflon exchange length wire.
Okay, so the strategy we use is, Nanda, are we going to use one proglide and one, or would
I think the size
or,
of the femorals are good, so I think we will straight away go for the two proglides.
so we're going to put two proglides. As you know that with two proglides, sometimes you get an indenting of the access side, but with large accesses, we are not, uncomfortable using two proglides. So we're going to just move the table up, please. Yeah.
Give me artery forceps for dilate.
So the most important thing in the proglide is to see that your proglide doesn't have difficulty in the subcutaneous tissue. So it's important to dilate and create a good access so that the proglides can go in smoothly. So Nanda will now show you how to put those proglides in. Yeah, you can load the proglides in.
Can remove the wire, sir.
So I'm going to remove the wire.
So
And
first one we are keeping at 2 o'clock.
so the first suture he's going to put at 2 o'clock position. So he's just ensuring that there's a good bleed back, then goes in further, then pulls back the hammer. And he cuts the suture in. Please. It's very important that you get a good access
What's this one?
area. And Nanda is ensuring that the sutures are now nicely clamped in with the forceps.
We'll remove this ones.
So we will now put the second one in, and that's the wire going in for the second glide. So we remove this one out. Sister, can we get the second pro glide, please? So the most important thing in transcatheter valve interventions is to see that you have good vascular access, and we normally use ultrasound mostly
Pressure.
and keep a watch all the time. One minute. So Nanda, can you explain the next
Yeah,
part?
now I am going on the 10 o'clock position.
So he's in the 10 o'clock
You can
position
remove the wire,
now.
sir.
Yeah, I'm pulling out the wire. He's happy with the position. He's pulling back. There's nice black bleed. Then he goes in back in and deploys the second one. Forceps, please.
Wires.
Wire.
Forceps.
Forceps, please.
Artery forceps.
It's very important that you take your time doing these accesses, and especially the site of the puncture has to be very, very clean. We use both angiography and ultrasound for these, and now again he's got the wire in for the second
Check fluoro.
proglide.
Okay.
So we've now got two proglides in, and we're going to remove Coaglide catheter. So
The dilators.
9 French.
now we'll have the dilators, please.
Illa 9 French.
Okay, 9 French. We'll put a 9 French.
Nine
This is
French dilator, please.
not stiff wire. Dilator vendadala.
And then we'll have the sequential
Yes, we'll
dilator
put a
here, please.
sheath. We'll put a sheath.
You flush that, please. Yeah.
Put a stiff wire, then we'll done.
Okay, can we get the stiff wire amplats, please, now?
JR. So we'll take JR with
So the important thing is to get good accesses. Now we flush the whole thing. We're given 6,000 units heparin. We got your proglides in, and now we're going to get a GR with an amplats wire for then sequentially dilating.
Can we improve the pressure? Pressures are
Okay, so now this is a stiff wire going up. Can we have the 9 French dilator, please? Ready?
no, so we'll just take the amplats. This is
This is amplats.
normal. This is not
Yeah,
normal Teflon, right?
yeah, just go up and then we'll use the amplats. So we get the amplats now, please. So as we discuss this case, you see this patient has already got a dual chamber pacing, but we cannot depend on that. And you can see a temporary pacemaker in because we need to control the pacing, which we can't do with permanent pacemakers. So it's very important that you have the temporary pacemaker put despite the dual chamber pacing being there. So we now remove this and we get the sequential dilator, please.
1 second. So what I'll do is remove the 9 French sheet.
Yeah.
Ready with the dilator?
Yes, please. Okay. 9 French. Get the bigger sequential dilator,
No.
please. Okay. Yeah. So as you know, we need to be very careful in the groin. And we're going to go sequentially up with a 9 and then a sequential dilator, which will get up to 14 French. As you know, the sheath is 14 French. Can we get the python ready? Yes. Keep it on the table, please. So watch the groin as we go up.
Can you show the femoral
propofol.
head?
Please show
Lalita,
down.
Propofol. இதுல என்ன இருக்கு?
It's very, very slow rotation
ஒரு bowl
as you
வேணுமே.
go up.
இது
All the
எடுத்துடலாமா?
time you're watching
இது
the blood
எடுத்துடலாமா?
pressure. And we'll keep that sheath in till 14. Yeah.
this is only.
Yeah, that's fine. Keep it in for a minute so that you have dilatation. This is all done under conscious sedation. The patient is sleepy and in fact snoring. Where's the sheath here?
Sheath is ready. I'm just getting prepared with the propofol for
Yeah.
Okay.
So we're going to put some propofol in so that we have nice local anesthetic as we go in. So the plan is now once the propofol is nicely placed over the sheath, the patient will have very little pain as it goes up. So the pacing has to be temporary. We have checked the pacing at various rates to be sure. So the next plan will be after we put the sheath in is to take a pigtail catheter and do an aerogram.
syringe
Check
to it as
two things. One is that you're in the NCC so that we can place the valve correctly. The second issue is to be sure that when we implant the valve, that we are looking at two things. One is there any coronary ostial closure? The left coronary height seems to be okay, and the sinus of Valsalva looks large. I don't think this is likely to happen, but an aortogram simultaneously during a balloon dilatation with an 18 millimeter balloon would help us to check that. So these are the two reasons why we would put a pigtail catheter. You could use a radial access if you wish to, but we have taken femoral in case that we have a problem in the coronary during balloon dilatation. Yeah. We could quickly access the coronary after keeping a guiding catheter and wire across in case the balloon closes the we are suspicious of the balloon closing the coronary ostium. Okay, so Ashish is on the groin. He's holding the groin, and Dr. Nandakumar will now help me with the uh, sheath. And as you can see the sheath, you can see it very, very nicely that it has got uh, a port on the side. It's 14 French, and we can go up to 18 French if we want. Up to 20, I think 23 millimeters, we have no problem. It can go to a 14. We'll go in very, very slowly now. Very important we do that slowly. So I'm putting a gentle tug on the wire as Ashish goes up. Please follow the sheet. So go up, please. So you see it's very smooth. I'm all the time watching the aortic pressure, and we're very happy with that pressure. Nothing is happening on the pressure side. So we've got that in now, and we'll now slowly remove the dilator and suture in the sheath.
We'll take out the wires.
Okay, so we get that out. Get me a suture, please.
Give it 25 ml flush.
20 ml syringe.
Okay, so by the time we'll get the pigtail ready for the left side, as by the time that Ashish takes the uh, suture in. So sister, can we get the pigtail, please?
So how you prepare the sheet, sir? Like you need to fully dilate outside, or you will half dilate and go in and dilate. What is the concept behind that?
Yeah, so the here I don't expect too many issues because we have a smaller valve going in. But if I have a bigger valve, I normally, in vitro, get an 18 French dilator into the sheath so it expands well. Because at times you may have difficulty in pushing the valve through the sheath. In this situation, I think that we may be okay because it's a smaller size valve. So 14 French should be good enough. Though 50% we dilate with the 18 French sheath. So we got this stuff sheets in now. We're making a small stitch, and we'll now go in with the pigtail catheter from the left side. So
White room, okay.
wire up. Yes, Ashish. Yeah.
Yeah, I mean,
Okay, so now Ashish is going to get the pigtail in over a floppy wire, and you can see the calcium in the aortic root, and you can see the valvular calcium, and there's also a MAC, mitral annular calcium. So we can see all that very, very clearly. So we're now going to be 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 looking at where
Oh, who's
the
over there?
pigtail is. It has to be in the non-coronary cusp. As you know, the views
Oh,
for
who's over there?
deployment are an LAO
who's it?
16
The rigid
cranial
portion is in.
0. That's the deployment view. And for the commissural
Okay,
alignment,
let's leave it.
as we
It's
get
okay.
the valve ready, and Dr. Nandakumar will explain to you how we do that. Okay.
Sure.
Trash it.
So we've got the pigtail in the NCC, and we'll take an aortic shoot now.
Can you come to the RAO just to confirm whether our pigtail is in the NCC?
So just coming to RAO just to be absolutely sure that your pigtail is in the NCC.
Some contrast. Yeah.
And we'll after that take a pigtail aerogram. Okay, so let's take a good shot with the dye. So we have some calcium which could help us also apart from the pigtail to know where to keep the valve.
3 value.
Okay, so we're going to use the anesthetic pressure. We don't have an an extra line. We use the right radial axis to measure pressure through the procedure. So the anesthetist will alert us. We don't want too many lines in the patient. You could also use the side port if you want to. So let's take a shot now. So go to the valve deployment view, please.
LAO 16 cranial 0.
LAO 16.
Plain
cranial
LAO
zero.
16.
Yeah. This has been decided by the CT.
All right. So, ready?
So this is a bit of an AR, but this is you can see the opening of the valve, and we will next get an Amplatz AL1 with a double length wire for crossing the valve. So please get the Amplatz, please store this on the right side, and we can go ahead with that now. Okay. So the aim now is to use an AL1 catheter with a double length wire to cross this valve, and after that we will exchange into a strong wire, and it should be a double length wire, please, sister.
So in the meantime, while you are crossing, let me discuss about this
Yeah. So
coronary
now
alignment.
Nanda will discuss about the valve. If we can see the valve from the camera, I'm not sure, but if you can see it from the camera, maybe Nanda, please go to the other side so we don't block the cameras. Yeah.
Give me a normal Teflon. Give me AL. Yeah, give me the normal Teflon. Then give me the straight tip.
So in the commissural alignment in this case, based
Normal
upon the
Teflon.
CT, we have got
Normal Teflon.
three native commissures, one at 10 o'clock, one at 2 o'clock, and another one at 6 o'clock. Though there are no standard guidelines to commissural alignment in the balloon expanding valve, we are working on some of the concepts like based upon the anteroposterior transition and the aortic angle. We have come to the final degree that 2 o'clock, if we position one commissure, it almost it's going to align with a 15-degree plus or minus with the native commissures. So with that, we are going to crimp one of the commissure at 2 o'clock, and post procedure at 1 month CT, we are going to check whether is it exactly aligning as per our hypothesis or not.
Back.
And there are published papers in Align TAVI trial, which actually for the balloon expandable valve, the concept is not great, because it not only depends upon the anteroposterior transition from exterior to interior, but also depends upon the aortic angle and
right.
Just give
ascending
me a dilator.
aorta,
Plain
ascending
dilator.
aorta angle from the arch.
9 or 6, anything is okay.
So is it going to be at 3 o'clock or 2 o'clock where the discussion between us in the commissural alignment? Then finally we thought that we will go for a 2 o'clock commissural position. Let's see how it gets aligned at 1 month.
Wire.
So this is the Merrill system, crimper system with a clock, so that we can easily we can align exactly at the 2 o'clock, 3 o'clock, 1 o'clock.
Yeah,
So what's
sorry,
this?
sorry.
You call this system as a crocodile?
Yeah. 1 second.
Crocodile.
Dilator, right.
core core align crocodile crimp system. So we can see from 9 o'clock to 3 o'clock the clock positions are there. Here in this particular case we are going to crimp one
Push it in.
commissioner at 2 o'clock.
So you can see sometimes the wire goes down the sheet side here. Anyway, Nanda, you can go ahead. It's just a small technical issue. We have to be careful with that. Yeah.
AL. The only question is now whether dial it because of the AR.
I will add it. Well, this is
We'll
ready.
keep the valve ready and then dial it. Why is he bleeding?
So now let's get the. You want a Terumo or a straight wire?
Straight
Wire?
thermo
Yeah.
after this.
Straight Terumo, please, double length.
Could you play
And
the
this
last shot?
coronary alignment, not necessarily we need to wait till 1 month to see the CT. Even at the end of this case, we can show it in some of the fluoroscopic views also. Best, I think, in the cusp overlap view, if we take the shot and we can see how the commissures are aligned or not. In this particular Myval, there is a marker at every commissures where instead of one frame, we can see
Timer,
two
please.
frames. So we can easily see the commissures after the deployment in the even in the fluoroscopy. Let's see how it gets aligned in the fluoroscopy at the end of this case. So you have crimped at 2 o'clock, right, with one commissure? And the skirt distal for aortic valve. So first confirm, I'm confirming skirt distal. You are also okay? Okay, right.
So you're just looking at where the valve is opening. It's a tight valve, as you know. It's 0.8 square centimeter. So there is a bit of AR, so that could help in crossing. So we normally use a wire and try for a minute with various positions. And if it doesn't cross, then we could use a stronger wire. On the higher side. Keep another wire ready, please. Keep the Teflon wire, please, ready.
Exchange lens straight Teflon.
Right now we are using a Terumo. If it doesn't cross, sometimes the Terumo gets deflected by the jet. Okay, so it's a minute, so we're going to flush and get us the Teflon wire, please. Yeah, flush it, please.
Lalita. Previous shot.
Put on the high side. So what we do is we try 3 times for a minute each and then change hands and see if we can cross it. I'm sure Ashish will be able to do that this time.
I think the orifice is towards more on the LCC side, little above.
It's a critical aortic stenosis, so we may have some difficulties in crossing it. This timer, please. Flush. Nanda,
Do
you
you
want
want
to
to
try?
try?
Yep.
Anyway, you try, sir.
Give me the wire again. Say why. So, soft wire, please. Keep an RCA catheter ready in case this doesn't go through. Can I have the RCA catheter ready? Can I have the Terumo for a minute? Terumo, please.
Yeah, just went in and come. Yeah,
Okay.
yeah, yeah.
It's just flickering it back, so that's the whole problem.
I think it just two times it went in and come.
Is it because the ectopic it is jumping out, or I don't know. Who's that? 6,000 தானே 6,000 தானே
Yeah,
Yes.
slowly, 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 slowly.
Okay. So double length pigtail, please.
We'll put a exchange length Teflon, sir.
Yeah.
Then exchange length J Teflon exchange length.
Okay, so we've just crossed it with a little bit of difficulty. And this is a double length Teflon, please. Yeah.
So extra small safari.
So this is to get a nice loop of the wire in, and then we'll put a
Pigtail.
pigtail. There's some ectopy, that doesn't matter. The pressure is allocated, doctor. Just watch the pressure anesthetist, Nanda. Okay,
We're holding.
so we got that out. And now we're going to put a pigtail in and then put this safari wire,
Extra small safari wire.
extra small.
So give me pigtail.
So we've got a wire in, it's a soft wire Teflon, and now we're going to put the pigtail, which
Keep
will
it
help us
straight.
to get the safari in.
ஒரு 3-way கொடுத்தாரு ரவி சார்.
Again, be very careful both
ஹை
of the
ப்ரெஷர்
wire
அது.
and the sheath as you go in. And there you're in control. Okay, safari wire and the balloon to be ready now after the safari goes in. Wire back.
Yeah, we'll do some hemodynamics and
They'll
then
give you, yeah, okay. So we're right to the apex of the left ventricle, and we're going to give you some pressures there.
இந்த
You
இது வந்து இந்த
disconnect
3
that.
ப்ரெஷர் இது கனெக்ட் பண்ணுங்க. Just high pressure, you can connect the pigtail the other side, I mean the injector.
Can we have the pressure on here, the left ventricular pressure? Prabhu, LV pressure, please. It's on.
Both the pressures.
Flash this. Flash both. Just flash this. It's not.
So ACT is
You want to
592.
flush which one? Red or blue?
Okay,
Ready?
so we're now going to get some gradients here and then show you after that, go ahead with the pre-dilatation. So just sort of, if you can show the hemodynamics. Yeah, thank you. So it's a pretty much big gradient. As you can see, it's about more than 85, I think. Close to
Yes.
90. Yeah, okay. So, okay, that's good. Okay, so now we get the Safari, please. Yeah. Safari wire, please. And can we get the balloon 18 millimeter mammoth? The mammoth is also a metal balloon, and it's a very neat balloon. And again, as I go up on the wire, I need to be very careful that I'm not going to get the pigtail jumping out. This is a very stiff wire, the Safari. And that's the Safari in. So I need that nice loop in, and then I will get the pigtail out of the way. So the mammoth balloon on the table, please, and the valve should be
It's ready,
loaded.
ready. All are ready.
I will
Okay.
take over.
ACT is 592. That's the reason.
Okay.
When you got the wire, tell
Yes,
me, sir.
please. I've got the wire. Okay, so let's get the mammoth balloon in.
Check பண்ணிடுங்க. Contrast. We're going to take a cine.
Yeah.
Prabhu. Prabhu.
Prabhu will meet it ready with the contrast.
Just aspirate.
Aspirate பண்ணிக்கோ first.
So what we're going to do is a simultaneous
Okay.
balloon dilatation.
Just check over there with at the annulus.
Okay, so balloon here. It's a hard gradient, so I don't like, even though there's AR, we may have difficulty crossing that valve. So it's better to pre-dilate. So please keep a watch on the anesthetic pressure, please. As you have no pressure here on the line.
You're
Okay.
holding the wire. Yeah.
So I'm just going
Watch
to
there
get
and hold.
the balloon across the
The wire
arch, and
comes out,
then
you need
we
to
will
adjust it
do a
accordingly.
check pacing. So please hold the wire.
Wire
Leave
in.
it. Leave it.
Yeah.
That's the mammoth balloon coming in. You can see the 3 markers, which helps us in correct placement. So before we cross, let's do a check pacing now.
Yeah.
140.
Yes,
140.
140, please. Yeah, so it's pacing
Okay.
What is
well.
happening to the pressure there?
We
Pressure
need a
we won't
little
have it over
higher.
here.
But we cannot inject now.
Okay, so what we'll do is stop pacing, please. Because we need a little higher pacing for the pressure to drop.
Shall we connect the pressure here?
That's okay. That's okay. So let's check once more with 180 pacing. 180 pacing, Ravi, please pace.
Hold the line.
Okay, that's good. That's good. Stop. Okay, I'll take the call for the pacing, please. And Nanda, you'll do the dilatation, please?
Yes, sir, sure.
So we'll get the valve down. You can see it's
Balloon.
quite hard to
Balloon.
go through. Okay, so that's good.
Fix.
So fix the wire, please. And Ravi, please pace.
Are we injecting?
Okay, go up, please. Okay, that's fine.
1001, 1002, 1003.
Okay, we'll now do one more dilatation just to check whether the coronaries get occluded.
Fluoro, sir?
Yeah, fluid.
Pacing
Stop.
off, sir? Yes.
I'll just pull it back a bit. So
Sir, stop pacing, sir. It's still. No, it's still pacing.
This is the pacemaker which is taking it.
okay, just overdrive him a bit.
No,
Overdrive.
no, sir. This patient is on pacemaker, no? I think maybe patient developed some atrial arrhythmia, so it started
Okay.
tracking.
Okay, it's settling down. Okay, good. I think the problem was that he has a dual chamber pacemaker inside. That may create an atrial tachycardia. That's what Nanda said smartly. So that means you solved that hemodynamic issue. So it's not a spontaneous VT. Okay, so now we need to inject. So are we ready with the injection? Prabhu?
Pressure's
I need a
off.
simultaneous injection, please.
So
Okay.
pacemaker ready, sir?
Are you ready, Ravi, with the pacemaker? Okay. Please go up. Pace, please.
Yes,
180,
please.
please. Yeah,
Okay, pressure
fine.
flat. I'm going.
going up. And
Inject.
inject. And there's enough room there, so there's no big problem there. Stop pacing slowly. Okay, very good. We'll draw the balloon out. Okay, let's get the balloon.
Cusp overlap
Draw
is
the
one
balloon
more.
back.
Cusp overlap.
Patient is stable. Pressures are good.
You're holding the wire, sir?
Yes, please.
Yeah.
Okay, so now we get the valve ready. As you can see, the pressures have come up nicely. The diastolic is still 5660,
You just
not
play the last
no
shot.
significant AR as before. So we can calmly do the valve now. It's a 23 millimeter valve. You can see that
Till இன்னும் கொஞ்சம் உள்ள போகணுமா?
At 23 we can go full, isn't it? Yeah. So I
I
think we'll
think
use a 23 and go full. Initially
23,
we
no
thought a
minus
millimeter
1.
less, but
No minus 1.
maybe it's a big sinus. I think we won't be having any issues with that. What do you think, Nanda?
Yes, I
Okay, so
agree, sir.
let's get the valve ready. Remember to keep the valve ready on the table uh, before you go in with the balloon. So we don't want problems with the valve. Yeah.
Pigtail கொஞ்சம் உள்ள போகணும்.
Fluoro, sir.
Yeah. So
Yeah.
the NCC. Okay. Good. Thanks. Okay. So as you can see, there's an
Parallel up.
introducer
Fix the
here.
wire.
Please hold the wire there.
Yes.
And
So
Fluoro,
we
sir.
have the logo,
follow it and go in
metal logo
slowly.
being up at 12 o'clock position.
Okay. Now I'm going up with the valve, and as Ashish holds the, just hold the wire back, please.
Yes, I'm holding it.
Okay, that's okay.
You can see that's a bit difficult.
Is the introducer fully in, sir?
Yep. So you need to slowly, gently push this off. There's a bit of arm required. Hold the wire back gently, Ashish.
Yes. We can remove the loader now.
Yep. I'll do that. Very important that you pull the loader out just because you don't get a splash. And you're all the time watching the pressure that it doesn't give way. Okay, just come to the aorta. Descending aorta, I think we're at the tip of the sheet.
AP.
At the
Come to the AP.
AP and the, so you can see it's right at the tip now.
This is always a problem.
So just show the top wire also if you can.
You're pushing with the sheet. Yeah.
Okay, so that's crossed there.
Constrict ஆகுது தெரியல.
And now as we
Come
go
to the
up,
LAO.
you can see how nicely it goes up. And Nanda or Ashish, please flex the, so if somebody can show the hand flexion,
Just the wire putting a flex பண்ற easier ஆகும்.
All right. So yes.
which is going to track down the ascending aorta. So you can see
we're
the
just flexing
flexor slowly flexing down so that the valve now easily tracks through that curve.
இது நான் பிடிச்சிரும் wire மட்டும் பார்த்தோம்.
Somebody hold the wire back a bit. Be very, very gentle.
இந்த டென்ஷன் விட்டாதான் இந்த டென்ஷன் விட்டாதான் அது
You have to
பண்றது
now.
ஈஸியா இருக்கும்.
Okay, so here it goes. Okay.
Yeah. So we have
So
crossed.
we're going to deploy it at 80-20s. So we'll do an aortogram now. Ready for an aortogram?
இந்த வியூ ஓகேவா? இது லாக் இல்ல. லாக் இந்த சைடா?
Are we ready? Watch the pressure, please.
All right.
I think we need to
We'll
come
come back.
We need to come back a bit. So I'm going to pull the valve back now.
Okay.
Okay. We'll do another shot, please. Again, we have that arrhythmia.
Should we need to go little in, sir? I think we need to go fluoro. Yeah.
Yes.
I think that's enough. Let's do an aortogram again. What do you think? I think it's okay, isn't it?
So I will slowly go in case if it's something moves, I think you can always adjust that.
So I think we're going to be happy with that position. And Nanda will do the dilatation. So we will now, I will
Check
take the
pace.
call for pacing. So Ravi, please pace and watch the pressure, please. Somebody. Yeah. Yes.
Should we go a little down?
Yes.
Sir,
Stop pacing.
sir, we'll go 1 millimeter down, sir.
Okay.
Mm.
Yeah, okay. That's good.
All
That's
check.
good.
Small checks there again.
Just rotate. Just rotate. Don't do anything.
Yeah. Take a shot.
15
Finish
mm.
shot.
All right.
Yeah, it
Yes,
looks
okay.
okay.
Okay. So we'll go back on the pressure here now. Okay, so now please space. Okay, go up please with the valve.
A little up. Okay. One,
Shall I go
two.
full?
Yeah, full
Yes, go.
please. Yeah.
Go. Go up. 2, 3,
1001,
4,
1002,
5.
1003.
Enough.
Deflate.
Deflate. Deflate. Deflate. Deflate.
Stop
Facing
placing.
off.
Yeah, just
All
shock
right.
please. Yeah, just shock please. Put the device and
Shock, shock.
All right.
okay. So we should be ready for all this. Just support the pressure for a bit.
Some volume and pressure, support pressure, please.
Okay, no pressures. Let me massage for some time.
Just a massage for a minute.
Table down,
Yeah, just a minute. Yeah, no problem. It will be settled
table
down.
down. Just check the floor echo,
Yeah.
please.
Please check the echo.
Echo and.
Okay.
Okay, okay.
Okay.
Let's wait. Just to
Wait,
see.
wait, wait.
How is the pressure?
No pressures. Okay, now pressures are coming.
Pressures are coming, sir.
Now pressures are coming.
Just support it. Don't get panicky. Just support. This is
We'll take a
normal.
shot or we'll check the
One
coronaries as
minute.
well.
1 minute. There's no ST change. It's just the.
We want no spacing rhythm.
It's perfect. Don't worry. That's the pressure on, and it's up to 80 now pressure, and it's coming up. So perfect. Just fluoro, please. So sometimes you see.
Reduce the depth and check for pericardial effusion first. Increase the depth,
Okay,
increase the
from this
depth,
side,
please.
and then that's okay.
Yeah.
No effusion on the
Any
pericardium.
T-lax and short axis.
any regional wall motion?
Okay, so it's all right. So your ventricle is good. You're contracting well. The pressure's up to 115. So he had a short PF. And that happens with these balloon expandable
I think
valves.
LV is collapsing, sir.
So get a
It's
volume in.
increase the volume. It looks like a suicidal LV.
The pressures are good.
Pressures
Don't
are better
worry.
now.
Don't worry. Just fix the fluids in.
Volume,
Just
volume.
fill the ventricle in. Okay, very good. So we're good now. So these are
take
the
a
small
shot.
issues. The valve is completely stable. So what you're going to do is now remove the valve balloon out and then take a shot. Okay. So we have got good pressures. We're getting the volume in. No issues. The valve is pretty much stable here.
Go.
Okay. Just slowly, Nanda. No hurry. So we see a few of these times, especially when you close the uh, when you occlude the aortic valve, especially yeah, okay, yeah, okay. You can get a VF.
All right, that's fine, sir.
Okay, so
Pull the
we're
wire.
done with that.
Down, wire
Pressures
is
are
down.
good. Pressures are 159 by 56. Perfect pressures, no problem. Patient is okay. Can somebody just speak to him for a minute if you can? He's just under conscious sedation. He's breathing well. Oxygenation is good. Pressures are good.
சம்பத் சம்பத் எப்படி இருக்கீங்க சம்பத்
Sedated, deeply
Sedated, okay.
sedated.
He's a bit sedated, so let's go ahead. Yeah, he's
Okay,
awake.
some good.
He's awake, so that's good. Okay, so now what we're going to do is a pigtail aerogram to check.
Wire.
So
Sir,
we'll get a
We'll
wire
take
and
a wire.
remove the
shall
pigtail
we
now.
push the
Yeah,
wire little in, sir?
I'm killing the
That's
wire in.
fine.
Yeah, it's okay.
That's fine.
Let's put a wire on the pigtail. So we've had almost in the last
Teflon, huh?
Teflon,
uh,
Teflon, Teflon better.
Teflon
many
போடுமா?
cases about 3 VFs, and we had to defibrillate them. The only worry about the VF is you can embolize the valve when you shock them. So we need to be a little careful, especially because we're giving a long dilatation across a closed valve. The pressure is good.
இந்த ஒரு 6 sheet போட்டுடுங்களா அதுல.
Slowly. Okay.
No, what is
Okay,
where
that's
pacemaker
perfect.
is
Yeah.
there?
Okay, let's now take a pressure, a shot.
So
Just
aspirate,
support it
please.
for some time. Yeah.
One
The
second,
pressure
one
is
second.
180 by 80, so no problem there. He's awake. Everything is under control. We do a shot now.
All right.
Are we ready for a shot?
Shuru.
We're a bit up.
Sinisa.
Okay. It's a perfect valve, absolutely perfect valve implant.
So
No
coronaries
coronary
are flowing.
obstruction, coronaries are flow. It's just a outflow obstruction because of a balloon expandable valve in a
Open
patient who has a
children,
very concentric left ventricle and who may get a
the
VF.
white
So I'm
line,
quite happy with this.
white
The
line
coronaries
stops
are
below.
flowing well. What do you think,
Yeah, it's
Nanda and
below.
Ashish?
Yeah, I think that the white line stops just below the level of the coronaries, the native valve,
Yeah.
Probably the
which they pushed.
leaflets.
It's just below the coronary level, so it should be okay. I think there
Okay,
need.
so this looks okay. You can see the white marker just below the left coronary, so that's okay. Okay, so let's now pull off this wire. That could be there.
Uh,
And
Give
can we
me
get
a.
the pigtail to remove this? Yeah,
You want to assess the hemodynamics?
yeah. So
We'll
we'll
give
get
a
the pigtail
pigtail.
down and assess the hemodynamics. So as you can see in the last shot, can you replay the shot as so it was a good plan to put a 23. As you can see, it's well implanted. And that white, which is the native leaflet, as you can see, is just below the left coronary. So
See, I
it was
cannot
a good
feel
idea
completely. I
to
stopped
keep a
here.
watch
I
on
cannot
that.
Hold the
push
wires
beyond
So
this
straight.
when
one.
you have blood pressures low during a procedure, you should watch for a few things. One is the pericardium, that you don't have a pericardial effusion. The second is coronary. But you could see in this patient that it was just the VF which had dropped the pressure,
Yeah,
nothing more
yeah.
than
So,
that. So here's a pigtail going to remove the safari. Be very careful when you remove these. Okay.
You can push it.
Okay, let's get that out. Okay, so we'll get some simultaneous pressure. So we have an aorta.
So okay.
So you can
So
see that the gradients, if somebody can watch the gradients there, it is 0. So we got a very nice gradient across the aortic valve. So from close to 85, we have 0. What is the end diastolic pressure, please? The LVDP is a bit high. We can expect that. We can, and then come back. So I'm going to remove the pigtail now from the cavity. So and take a shot
normal
into the
Teflon wire.
cavity.
Normal Teflon wire.
So the Merrill valve has performed extremely well across the aortic stenosis. We put a 23 valve and it really has no gradients and hardly any leak. So we're now going to get that pigtail out of the way and that's out. So
just to find the cusp overlap view,
keep that.
I think. Tell me
So
what
you
is the
want a
cusp
cine
overlap
of
view?
you want a cine in the other view?
We will take a cusp overlap view one cine with a shot to check the
Yeah.
coronary alignment.
Okay.
Orevo?
So we're going to take one shot just to be sure that our cuspal alignment was okay.
No,
And following that, we'll pass you over to the
show
other
the
lab
diagram.
so that you can show a very good case which is ready on the other lab.
Why it was not written here?
So I'd like to thank everybody. So it was a real difficult aortic stenosis, tight stenosis, difficult to cross. And the post valve deployment, we had a short VF
Next.
which had to be
Yeah.
cardioverted and
What is
had a
this view?
small
RAO
CPR
9.
for 30 seconds. So the pressures are
RO
good
9.
now. It's on hardly any support now. So it's a
Very
not at
minimal.
point not 5 with a pressure of 143 by 79. So there's no AR at
Mm.
all. And now we're going to take a shot to check the coronary, uh, coronary
RA19 caudal 35.
commissural
Fluoro, you
alignment.
are in fluoro.
So
Yeah.
Okay, so in this view, in the fluoroscopy, just do a scene. See, if we can see, there are two parallel lines. Those are all the commissural areas. So it looks like this is a cusp overlap view of left coronary and right coronary cusp. It's maybe 15-degree apart, separated. So the commissural alignment is also going to be 15-degree plus or minus, which is going to be the best alignment according to the classification. So let's take a cine and see. Is the left coronary is coming just in between these commissures on the right side of our hand or the screen.
So
Okay, one cine please.
ready? No, no need to aspirate.
Oh.
Ready?
Yeah, I think looks like the commissural alignment is there, plus or minus 15-degree.
So you're happy with that, Nanda, the
Yes, sir.
commissural
Yes, sir.
alignment? Can you
Yes.
just explain it once more before we close?
So the commissural posts in Myval are seen like a two parallel lines. Instead of that frame, connected frames are single lines. Only at the commissure is two parallel lines. So we can see, yeah.
Oh,
So
it
there
cannot
is one
show.
commissure on anterior and one commissure on posterior. If it overlaps both the commissures exactly, it is 0-degree alignment. Now it is little separated in a cusp overlap view. So it is going to be like
Around
15-degree, 0 to 15-degree alignment. And the third commissure is on
the
the
left side.
NCC aspect,
Yeah.
which we are not seeing because it is exactly falling on these things. And in the cusp overlap view, both the coronaries are going to come between these commissures. So left coronary is coming exactly between these two commissures. Hence, I believe the commissural alignment is going to be somewhere between 0 to 15-degree. Anyway, we will confirm that with the
Yeah, a CT
CT.
later. So what this has shown clearly is that it's possible to externally decide after a CT reading for commissural alignment. So simply, you need two posts on the left and right side, one overlapping the other, and one post on the non-coronary, and then you are commissurally aligned, technically, if they overlap. Now, there's a minor disalignment of about 10-15 degrees, but that's acceptable. So I think we'll decide that on the CT. So let me just close this case now. It
And
was an excellent aortic stenosis, a high gradient, difficult to cross, pre-dilated with 18, a little short coronary on the left. We had to balloon dilate to check the closure of the coronary and also to pre-dilate the valve. We got a 23 millimeter valve at full balloon inflammation, had a short VF with a short CPR, which is not very uncommon during TAVA, and we need to get ready for these things. And we got a good result with zero gradients and no AR,
yeah,
with a diastolic of 30, and the pressure now is extremely good at about, we are off almost all supports now. So we are going to per
I
close,
think
but at the end of the
protometer
day,
responded
thank you
now.
very much for joining us. And